Welcome, doctors. Today, we are reviewing a clinical blueprint for aesthetic risk assessment in implant therapy. Before we even pick up a scalpel, we must recognize that success in the anterior aesthetic zone is dictated by careful preoperative case selection. This presentation provides a comprehensive visual framework for evaluating the systemic, anatomical, and site-specific risk factors that will ultimately determine our surgical protocols. To avoid missing critical liabilities, we categorize our clinical variables into a structured diagnostic sequence comprising 4 quadrants. We evaluate the patient profile, 4 systemic and psychological baselines, the soft tissue architecture, 4 mucosal integrity, the hard tissue foundation, 4 bone anatomy, and finally, site and restorative anatomy. Let's break down the risk levels within each of these quadrants. We begin with the patient profile. For medical status, we assess the immune system and physiologic healing capacity. Compromised healing immediately places the patient at high risk. Next is the smoking habit, which profoundly impacts microcirculation and graft survival. A non-smoker is low risk, but a heavy smoker consuming more than 10 cigarettes per day is categorized as high risk. Finally, we must evaluate aesthetic expectations. If a patient has unrealistic treatment goals, this is a psychological high-risk factor that must be addressed before any treatment begins. Moving to soft tissue architecture. The gingival phenotype is critical for resistance to midfacial recession. A low scalloped, thick phenotype is low risk, whereas a high scalloped, thin phenotype is prone to recession and represents a high risk. We must also evaluate the gingival display at full smile. High visibility of the restorative margin puts us in the critical aesthetic zone, elevating the risk. Lastly, the presence of any pre-existing soft tissue defects in the facial peri-implant mucosa is a high-risk indicator. Our hard tissue foundation dictates long-term volume stability. The facial bone wall phenotype is a primary surgical determinant. A thick wall of 1 mm or greater is low risk, while a thin wall of less than 1 mm is high risk because it is comprised almost entirely of bundle bone that will resorb. We also measure the bone level at adjacent teeth. If the distance to the contact point is 7 mm or greater, interproximal papilla support is severely compromised, marking a high risk. Additionally, any vertical deficiency in the alveolar crest anatomy is considered high risk. Next, we analyze site-specific variables that impact our ability to perform immediate placement. Infection at the implant site is a strict contraindication. Acute pathology requires us to abort immediate placement and delay the protocol. The width of the edentulous span is also crucial. Missing 2 teeth or more compromises the central papilla and is a high-risk scenario. Finally, we observe the shape of tooth crowns. Triangular crowns are high risk due to unfavorable papilla morphology, and the restorative status of neighboring teeth, where heavily restored adjacent teeth limit our prosthetic flexibility. This brings us to the master ERA matrix. This chart synthesizes all 13 variables into low, medium, and high-risk columns. As clinicians, your job is to map your patient's specific presentation on this matrix. If a case falls predominantly into the green low-risk column, it may be suitable for a type 1 immediate implant placement. However, if you identify compounding variables in the red high-risk column, such as a thin facial bone wall, thin gingiva, or acute infection, you are dealing with a highly complex case that demands alternative timing, such as a type 2 early placement with simultaneous contour augmentation. In conclusion, how do we use this clinically? It is a 3-step active workflow. First, risk profiling. Utilize the master matrix to identify compounding high-risk variables prior to any surgical intervention. Second, patient communication. Leverage this visual risk mapping to align the patient's expectations with their physiological realities and anatomical constraints. Third, surgical execution. Use this data to adapt your grafting protocols, adjust the timing of implant placement, and modify prosthetic designs based on the specific liabilities you identified. Strict adherence to this blueprint prevents aesthetic disasters. Thank you.